is a given. Discuss the hospice facility partnership, which we do have a contract with Havenwood here. Goals of pain management, and what kind of medications are used and route they are given. First of all, what is hospice? And hospice is a special kind of care for dying people, their families, and their caregivers. It's a comprehensive program that meets the physical needs of the patient, and up there, it's still pain management is one of the focal points with hospice, but we really want to stress that a patient does not have to have pain in order to be referred into hospice. And we hear that a lot when we're out and about to say, we're thinking about hospice, but the patient's been comfortable. What could you do? That's usually when we can help the patient better. If we know them at more of like a baseline point, we can better help them when we have pain. And it's not on any of the screening tools for admission. So,
and the other thing with that is people don't realize that families' emotional pain, that they're going through the grieving process. So sometimes even if the patient themselves are not having pain, maybe we can educate the families, educate them on the dying process. It'll help them through this process.
And spiritual needs. A lot of times that's something people don't want to talk about. People have maybe had some beliefs but never really had anybody explore them or help them to get reconnected. And you'll find oftentimes the beginning of life, the end of life are times when sometimes we need that extra support. So part of the program also is helping to reconnect people with that. And oftentimes in traditional medicine, those aren't things we look at. We're thinking of the physical needs and not so much the emotional and spiritual needs. And truly, in my time with hospice, some of the toughest cases we've had every med imaginable to try to help someone's pain. And we've all concluded as a team that this patient was dealing with emotional and spiritual pain. And guess what? Medicine doesn't help that. So we had to help this patient on other levels. So just always think of that too for patient needs. The basic principles of hospice care are that it affirms life, and that's the most important thing. So oftentimes people, and we'll have families even if we're working in a home, come running out to the car and say, we know you're here from hospice, but we don't want you to talk about dying the whole time you're here. Well, we don't do that. In fact, we're affirming life. We're talking about patient goals. What can we do to make them feel better so that they can live their life, so that they can get back out, so they can do things? Here in the nursing home too, what things can we do to help them to have a better quality of life? So it's not dwelling on death and dying. It's helping them to live as best as they can for the time that they have left. It regards dying as a normal process. So oftentimes in healthcare, if we can't do anything to fix a patient any longer, they almost feel lost. And hospice welcomes those people. When there's no more treatment, maybe for an illness, what can we do? We can focus on keeping them comfortable. We can manage symptoms. Those are all things we can do that sometimes the healthcare system doesn't look at. Plus, we can help them along the way. It's so oftentimes, and many of you, I'm sure, working in the nursing home, you'll have conversations with patients, and they'll say, well, I'm not afraid of dying. My wife has been dead for many years, but I'm afraid what's going to happen from now until I die. What will that journey be like for me? And that's really oftentimes what patients have fear about. So we try to help them through that journey and help them explain to them what's normal. Sometimes it's not quite so frightful for that patient and for the family too. They don't know what some of the normal changes in the dying process mean. So a lot of our work sometimes is, sitting with the patient, sitting with the family, just talking about some of those things.
And the things, the word term that I have learned over the years to use instead of using dying, where you're at end of life, where you are at for your symptoms are at end of life, instead of hitting the words dying, because dying is a bad term for most folks. And so if we were able to do that and say, this is normal for where you're at, your body is slowly shutting down because of where you're at in the disease process. And they seem to be able to relax a little bit as long as they know they're normal.
And then another principle is obviously relieving pain and other symptoms. And it integrates the medical, psychological, and spiritual aspects of care, which is kind of what we talked about, and offers a support system to patients and their families. And really here in the nursing home setting, sometimes that family support, that extra time that it takes to teach them, those extra phone calls that you get at night or on the weekends because they don't know what's going on. So that's what we do. That's what we're about. So it's perfectly appropriate for staff here to tell the family to call hospice. You know, if you're busy at your nursing station, you guys have a whole building of patients to care for. That if there are more hospice specific questions, it's perfectly appropriate to say, you know what, those are questions you can talk to the hospice staff about. That's how we're providing that extra level of support for them. And we do tell the families that at the admission process, but sometimes I think they have this mindset that the nursing home staff has to call hospice. And we tell them, you know, this is our number, we give them a card, and say, if you have questions, you can call us. So I think it's just a constant teaching process and letting them know. Because that's what we do in the home setting. You know, there aren't any staff when you're working with a patient at home, and we want to try to be the same support to your facility here. So that is a resource that they can call us. We have a nurse with hospice working 24 hours a day, 7 days a week. So just so that you're all aware of that. And then who is eligible for hospice? Actually, the way the program is set up, it's for anyone who has a terminal diagnosis and is expected to live 6 months or less. Well, how can we expect if someone's going to live 6 months or less? You really can't. So it's a very gray area. In fact, how the Medicare language is written for physicians, it says if this patient's disease would run its normal course, which again, what is normal? We don't know, that's the gray area. Would you be surprised if this patient would live longer than 6 months? So again, it's kind of a gray area, but we use that to get somebody admitted into the program. If there's somebody that, you know, they've been deteriorating and the physician sees that decline, we can get them admitted. And then we'll talk a little bit more about how the program is set up, because sometimes patients that we admit, things look pretty grim that day. Well, then we'll look at them 3 months later. Well, guess what? They're exactly the same. Sometimes patients improve, and then we have ways that we can work with that. But we'd rather get a referral early because there's more that we can do. When a patient is literally on their deathbed, and I know we had a lady a couple weeks ago, she could have died actually during the admission. Really, what did we do to help her or her family? Not much. It was just crisis 911. You know, it was really almost too late. And then we listed some of the different illnesses that we do work with. Like I say, when hospice started, traditionally it was mainly cancer patients that came into the program. And we were talking in the office this morning, I think we're about 30 patients. A very low percentage of those folks actually had cancer. So we're seeing more people with some of these illnesses, like end-stage pulmonary disease, end-stage liver disease, end-stage cardiac, HIV disease, Alzheimer's, or different forms of dementia, renal failure if the patient has chosen not to have dialysis to prolong the illness, stroke or coma, cancer, and then other end-stage disease processes, like Parkinson's. Let's say we've had some Parkinson's patients.
Multiple sclerosis.
Mm-hmm. Yeah. So again, it's definitely opened the door that more people can get services. And Medicare has it set up that we actually have screening tools where the nurse would come and do an assessment to see if that patient meets the screening criteria for admission. And then we do have to contact the patient's doctor for that certification of the 6 months or less life expectancy. That's one of the scariest things, I think, when patients who've been living with end-stage heart disease for years, you know, and they see that, And so we explain it that way, you know, it's just a guideline, and, I remember I worked with a man one time, and it was horrible, because at his 6 months point, and he had heart disease, he was actually doing pretty good. He had deteriorated, but, and I know he said he was crying one day. I went to see him, and he said, "Today's the day I'm going to die." And I said, "What do you mean?" I mean, he really was doing pretty good. Guess what day it was? The end of his 6 months. He literally thought, you know, so I mean, that's one of the hardest things I think that we deal with. It's just a guideline. And it's interesting, we've had patients on the program for a year. I think our longest ever was a lady we had for 2 years with heart disease.
And with our screening tool, what majority will trigger a phone call or a referral? Weight loss. Number one thing, if they've had weight loss in the last 3 months, 4 months, you know, you've seen a majority of the weight loss, not eating very good, that will trigger referral. The other thing, infections, upper respiratory infections, UTIs, that will also correlate, and they have more morbidities like diabetes. If they have that, that complicates their disease process, and so that is one of the things that we kind of look for. Yes?
So it's still the same, that you have to refuse or not take dialysis before hospice can help?
Depends on what we're admitting the diagnosis for. If we're admitting a hospice patient for renal failure, then yes, they have to stop dialysis. If it is a heart condition, they do not have to stop dialysis, because what we are paying for are the heart diagnosis, so the heart meds, and we're not worried about the kidney problem.
It would have to be, the dialysis and renal failure would have to be unrelated to the terminal condition. Like, let's say if you had brain cancer or something, and you also had.
Yeah, Steve had all that, and still, back in 2005, and they still went.
It depends on what the doctor said what he's going to die from.
Yeah, and it is sometimes, you know, so much of your body is interconnected and interrelated. But
There's
yeah,
a lot of
they
gray.
have-
It's
There's
not
a
black.
lot of gray areas.
Yeah,
So.
it's not always black and white.
And we always try to do our best, and we have, Dr. Will is our medical director, so sometimes if a primary physician is maybe giving us a hard time, we'll ask him to review the case and help to be the advocate for that patient. And I think he's really helped us, because we've had a couple like that, where it's a really gray area, but yet the patient and family needs services and they need help. So sometimes he's helped the primary physician see that. And then patient rights under hospice. You know, hospice is something that a patient has to agree to, and they have to be informed of being in the program, and we actually go through all of that with them at the admission. And it's also a patient's right to be informed if they're at the point in their illness that they could receive services. So meaning, you know, here in the nursing home too, you know, there's nothing wrong, and I know sometimes that happens in care conferences to say, you know, or a doctor will bring up that, you know, you might be to the point in your illness where you would have the right to receive services. It's a benefit financially to some people actually to have hospice services. And then of course, they always have the right to refuse the services. But we always feel it's good for them to at least know about it, and then they can make the choice from that. When I say patients, in some cases, it's a family member. You know, the family member that's been legally chosen to make decisions for that patient. And then payer sources for hospice. Probably most of the people we see here were billing Medicare for hospice services, and I'm saying that because I'm assuming most of your people here are over 65 and receive Medicare. The big thing is Medicare does not pay nursing home room and board charges and hospice. And it's too bad, because there are some cases where a patient probably could benefit from services, but they're using their Medicare to pay facility, room and board, and families just don't get this. We can tell them over and over. But unfortunately, Medicare has not budged on that at all. So oftentimes we'll have to wait for the Medicare coverage to stop, and then we admit a patient into hospice services. Commercial insurances actually have gotten very good when it comes to paying for hospice care. And there are just a couple listed there, Blue Cross, Health Partners, Medica. Most of them will match the Medicare payment for hospice services. And the reason being, it's generally more cost effective to have a patient under hospice care than the regular commercial insurance. It generally reduces hospitalizations and other costs. So I don't think we've had trouble with any commercial insurances. MA and Prime West, I'm sure many of you have heard of, they're actually very good too in covering hospice care. A lot of our younger patients were billing MA for their services. What's nice is in the nursing home setting, medical assistants will pay for their room and board and hospice at the same time. So that's just something to know about. In the VA, believe it or not, they have gotten very good too. They will cover hospice services. They also will cover room and board for their hospice patient, but it has to be in a facility where they have a VA contract. And right now, Nielsen Place is the facility in town that will do that. So if your veteran is hospice eligible and needs nursing home placement, and if I'm understanding right, it doesn't even depend on their service-connected disability, which is a miracle. If any of you have ever worked in the VA world, and this is a great benefits for veterans to know about, that they can get their nursing home paid for and their hospice services.
And this is pretty new. This program has been evolving over the last 3 years, so it has been really a new
A new thing.
for the VAs.
But if any of you have relatives, elderly people, it's just a resource. If they've served in the military, it's a benefit that they have. And they are trying to do more to promote that. And then, of course, private pay. And over the years, we've had some people who have paid privately for services. And then charity care. And charity care would probably be more for people that aren't low income enough for medical assistance, but yet don't have any health insurance to cover. And it's not as great as it sounds. You have to go through an application process to apply for charity care. But for some people, it's worth it, and we can do that. We can help people with that.
The one example of here, we have a gentleman who was young, he was in his 50s, and his insurance ran out. And what we ended up doing, because it was cheaper than paying for his whole hospice thing, was we paid the insurance premium out of our hospice
Restricted funds or donated funds.
so that he could continue with hospice and get the service that they needed, and it wouldn't be a family hardship for them.
In hospice, given to a patient in their home, because again, I think traditionally most people think of hospice in a home. Obviously now we can come into nursing homes, and that's a patient who's at home with a caregiver. We can also provide care to assisted livings and adult foster care homes, in nursing homes, and it says in a rare occasion in a hospital, and that's if a patient would meet the inpatient level of care. So let's say they're on, TPN or having some pain management problems where they require that inpatient level of care, the hospice can still follow that. So something just to know about. When is hospice care appropriate? And the referral is generally given to hospice when the patient gets the news of a life-limiting or terminal illness, and that the Medicare guidelines, meet that the physician can certify that a 6 months or less prognosis. And so what we do a lot of times, more in facilities, if there's somebody you're even thinking might qualify, just call us. We can do a no-charge assessment or a screening, just to let you know where that patient is. Sometimes we have gotten referrals where they've been too early, but then it's nice because then at least we can tell you what to look for as that patient changes, then what might be a good time to call for help. And this is where I was talking about the service period for hospice. And this is where it gets very confusing to family members, but for all of you, you should be able to understand, we have to certify that the patient is eligible for for care, and so we can get them admitted into the program. And then for the first 2 certification periods, those are each 90 days. So at the end of those 90-day cert periods, we have to go over and redo the screening tool, just showing how the patient is doing. After that, it's every 60 days. The new thing that's changed, and it's not on here, and it's important for you all to know about it, is Medicare now requires the hospice medical director to make an on-site face-to-face visit of every hospice patient who's in the program for more than 6 months. Well, as you can imagine, Dr. Will thought, oh my gosh, how am I gonna do this? Because we cover such a big service area. We go to North Home, you know, we're down as far as Walker almost now, but he has done it for us. And same thing here in the nursing home. If we have a patient here on service for more than 6 months, Dr. Will, you might wonder, you know, if a different doctor's a physician, what is he doing here? But we'd let you know about it too. He has to come to certify that that patient still meets criteria.
And Dr. Will is our medical director. He has to sign all the paperwork, and so it's his license that is signing for the hospice care,
And that's
along
what's
with
to
the primary.
his best interest, obviously, to make that home visit, or nursing home visit, And there are times he's gone out and he'll tell us, you know, I don't think so, the lab maybe looks too good or something just isn't right, that he's not comfortable with it. And then we do have to start a discharge plan for that patient.
And the hard part about that, Dr. Will has to do that within 14 days of the research. For us, our policy is we try to allow families and patient know 10 days prior to discharge so we can get everything done. So if Dr. Will doesn't make it out there for that 7 days, you know, that we're out of compliance with our policy part. So we really have to work fast, especially if there's one questionable, we try to get them right there at that 14 days. So we have that 10 days to get them switched over to either another program, discharged to home, whatever else they may need.
We've had problems, not at your facility, but at another facility, that for the patient to be in the unit where they're at, they have to be on hospice care. And the facility might not have another bed in the facility where then we're looking at transferring that patient. So those would be the cases where, you know, you really want to do your planning as early as you can. Any questions on that, or how Medicare is set up? And then hospice supports the caregiver, which again, here in the facility, all of you as staff are the caregiver. And again, it's physician services, spiritual care. Pastor Mark Pappy-Larson is our hospice chaplain, so he's available to come see any of your patients here. If staff would be having a particular issue, he can meet with staff. We have the home health aides, and they're the ones that help with the personal cares, that we can have them come to the nursing home too. They generally don't replace the normal bath day or shower day. They provide supplemental care. And the families usually, and the patients like to hear that that's something that we can do. And we have volunteers who do respite care here in the facility. I know, I can remember, sometimes we'll get a call that a patient is real restless at night, and could we have a volunteer sit with that patient? We have a volunteer harp player that can come to the facility. So it's just some of those extra pieces. And then the hospice nurse and social work services. And Becky will talk a little bit about the bereavement piece later and how that works for even nursing home residents, if it would be needed.
Any questions so far? We haven't lost you yet, you're not speaking. Good.
Okay, bereavement after patient death. I read this yesterday that bereavement means to be deprived by death. But this means emotional, psychosocial, spiritual support and services to assist with issues related to grief, loss, and adjustment. And so our hospice program offers bereavement services to family, loved ones, friends, for a minimum of 12 months, usually up to 13 months following the death of a patient. And oftentimes, we, after the death, I will contact the main contact person and ask if they'd be interested in visits, phone calls, and mailings. We send out mailings too. and then they'll let me know what they're interested in. It's interesting how many people are comfortable with phone calls. Yeah, why don't you call me every month to see how I'm doing? And other people, again, like the visits, and then some just like the mailing. So there's just a diverse group of people that prefer different services. And so with the phone contacts, again, we'll decide if they want monthly phone calls, or maybe every 2 months, or maybe 6 months down the road, because right now they feel like they are doing very well. But maybe a few months later, they just want a contact. Short-term counseling can be offered. Assessment of needs and referrals to community, we let them know what services are available in the community too. They need additional services. Support groups, we let them know about the grief support group that is ongoing on a monthly basis. Any educational forms that are coming up, we'll let them know about that too. Written information on grief process. Memorial services, we try to attend each of the funerals or memorial services, if we can. And then once a year, a community remembrance service is co-sponsored by Hospice and the 2 funeral homes in the area. And that's a nice way to remember people that have passed on, and family members can come to the service. Usually it's at one of the churches. We've been having them in November or December. And then we read the names of the people that have died, and music is provided, a short message, and some refreshments later on. But it's a nice time to get together to visit with some of the people. Anything else you
And
want?
once in a while, we have a very traumatic death. Traumatic death meaning it was out of the normal process course of a death. And sometimes with that, then as a nurse, I will try to go out with a social worker and make a visit, first contact visit with them in their home. One case in particular, this gentleman had cancer in the lung, which wrapped around his aorta and up in here. And when he ended up having a coughing spell, and he coughed up, and he ruptured his aorta, and he looked like mass murder, where he threw up blood. And for that, the wife was very traumatized. And
It's
so,
like a post-traumatic stress disorder.
because she saw him in the bedroom, and when I went there at the time of death, it looked like a mass murder in the bedroom, because that sprayed blood all over. And for that, we kept in contact with this family member for 2 years. And she had a lot of questions for the primary physician. She had a lot of questions that, she repeated the questions every time we were meeting her, first of all, monthly. We would go and we would take her for lunch, and then she would start going with her questions. And it took her that long to keep processing the same questions and same answers over and over until she finally was okay with it. And that was the most traumatic one that I've been with, that we've had to deal with.
And really with grief counseling, in doing this for so long, letting that person tell their story, although it may get monotonous, is the most healing thing for them. And sometimes it may take several times, or they come into the nursing home after their loved one has died, but just even sitting there and listening to them tell their story makes all the difference to them. You know, an interesting dynamic that I learned too at a grief workshop, and I always keep this, in the back of my mind. They say with long-term marriages or couples that have been together for a long time, when one is placed in a nursing home, we don't really think of that maybe so much from a grief perspective, but they say it's very traumatic, that initial separation of that couple when one goes into a nursing home is very, very significant, more significant than anybody even, pays attention to, because the study that was done showed death, and the deaths of loved ones who died in a nursing home where the spouse was in the community, their grief response actually was less because of how much grief had been done when that spouse first moved in. So I never really thought about that. Of course, it's difficult, but it's actually initial grieving. They do a lot of that when they're initially separated.
Bereavement services are available to the residents, roommate, and of course that's if they're close, if they've been roommates for some time and they know each other well. And sometimes a person is just placed in the room and they barely know each other, but if they are close, we can provide bereavement
This
services
was
to
actually
them.
one of the new regulations that had come out, and we thought, oh my gosh, how are we gonna handle this or do this? And the more, in fact, even with our survey process, you know, they basically pointed out that it would be more in situations where, let's say, if roommates had been together for years, you know, just things that we probably don't see quite so much of here, but it is something to keep in the back of your mind. If you ever would have that close relationship and a resident really grieving the death of their roommate, you can offer them us in our bereavement program as a resource to them.
Bereavement services are available to family members, friends too, that have been caregivers or friends that are very close to the patient, and the staff caregiver who experiences grief from the loss of the patient.
An example of that too is we had one patient in the hospital and that was very connected to her. She was in there for a long period of time before she was a hospice patient. And what we found was it was better to do the one-on-one instead of a group type of agreement process. And we set it up with our chaplain, Mark, and other folks to help them through the agreement process, because they were the initial caregivers for such a long time.
The Hospice Facility Partnership. You, the nursing facility staff, become part of the interdisciplinary team when a facility resident elects hospice care. And so it's very important that our communication lines are open. We can't stress that enough. Important for each provider to recognize each other's knowledge and remain open to two-way learning. The nursing facility staff are skilled in meeting the clinical and psychosocial and spiritual needs of their residents. And hospice staff are skilled at meeting the special clinical, psychosocial, and spiritual needs at end of life. So if we can work together, it's just going to be to the benefit of the patient and family and friends.
And if you can think, once we take on a patient or a resident in your facility, you are now part of our hospice team. You are a portion of that with us.
And that's what we have you sign the primary caregiver sheet when that patient gets admitted into the program. So it's, you know, in our record that the nursing home staff has agreed to be the primary caregiver for this hospice patient. And one thing I just want to add here too, as I'm thinking, and because this has been an issue in our office, is the time of death. And obviously in the community, because of law enforcement and legal issues, we have to go to the home at the time of death, or it causes huge, huge problems. Here in a nursing home, we've always kind of had that more, you know, because you guys, you know, handle death too all the time. But when it's a hospice patient, we've been kind of talking about what is our responsibility to responding to that death.
And it's very important, if there's, especially if there's family here, and if they need us, we always offer us, we will come. No
Even
matter
if it's in the middle of the night and you have a caregiver here and, you know, they need support, don't hesitate to call us, because we're supposed to be offering that to your staff here. And it can be time consuming if they have a lot of questions. Sometimes they just need somebody to be with them, and you can use us for that resource.
And it is a big thing for some family members to be able to see somebody from hospice. So if you have, you know, and they're here, and always offer us, we will come. It may take some of us a little longer to get here for where we live and the time of the day, but we will come.
Okay, with the hospice facility partnership, there's combined expertise which allows the nursing facility and hospice to deliver the most comprehensive care of patient and family possible. And the successful partnership between a hospice and nursing facility include acknowledgement and respect for each other's regulations, developing an excellent communication process, consistent coordination of care by the hospice and the nursing facility, and identification of care plan in both the nursing facility and the hospice medical record. So consistent communication, coordination, and documentation are keys for success. partnership with patients, the provision of high quality and coordinated care, end-of-life care is a win-win scenario for a patient and their family, a nursing facility and their staff, and for hospice and for the staff. Do you have any questions?
So now we're gonna kind of go into some of the end-of-life symptoms that we see most of the time with families and patients who are living with a life-threatening illness. They may have other symptoms that they may have. They can be physical, emotional. And so then we try to kind of see the big picture when we come in with the families and the patients, with see, do we really know what's going on? That's why we ask a lot of questions sometimes. Do you feel, is it emotional? Do you feel it's spiritual? Are they having pain? To try to figure out what's really going on with them. And some of these symptoms can be related to the primary illness. Others can be related to the adverse side effects of the medications that we give. Medications are wonderful. I give you some morphine, some MS Contin, what happens? Constipation. So what do I have to give you now? I have to give you some Seneca to get so they don't become constipated. The number one pain, if they can't pee or poop, that is a big pain issue that you just created from the narcotic that you just gave. So what our standard is, and we usually look, if someone is put on a newly medication of morphine, OxyContin, is there a bowel program? Is there something to contradict the sluggishness of the narcotic use to get the bowels regular? And so that's one of the things that we should have in all patients and stuff in your nursing home when you're doing orders. Hospice care also manages symptoms to promote comfort and quality of life. We're not looking at quantity of life, but we're trying to make their quality of life, meaning that we're gonna, if they're nauseated, we have different medications we can try to get their nausea under control. A lot of times we start now with Compazine and Phenergan, but now Zofran is now a generic, and we can use Zofran freer than we could in the beginning. And that one you can just put in the tongue and it dissolves. We've gotten away from having to use a lot of suppositories, which is wonderful, because now you can do most of them buccal and different things. So that has been a real thing for dignity for a lot of folks. Common end-of-life symptoms is pain, which again we said was physical, emotional, or spiritual. Shortness of breath. I just can't breathe. And they may not know. And it might be a heaviness, from fear. It could be from the disease process. It just, their body's getting weaker. The blood's not pumping to their, through the heart and the lungs as well. They're not perfusing the oxygen supply in their system. And so that all comes when their body's getting tired and starting to shut down. The nausea and vomiting. In our homes, we have a B kit and E kit. And an E kit, we always have stuff in there for nausea rectally. We have generic Compazine. And we also have things to get us through a crisis. So usually you folks have an E kit in your facility, and that's what we use. Out of your E kit. And then we get whatever you need the following day. So that's why it's important that you notify us as hospice staff. If you're using something on your E-kit, let us know so we can get you the meds and stuff you need. Anorexia, people don't want to eat. You put a big plate of food in front of them, they're going to push it away because it's too overwhelming. So usually by this time they're eating very small bites. You may have to do 6 meals a day instead of the 3. You may do supplements in between. They're coming weak. Fatigue, you might see them falling. They just can't hold up. They're using walkers now. Maybe they can't transfer at all. Maybe they have to use an easy stand to a wheelchair. And then we talked about the constipation. The one thing that's very hard sometimes is delirium. Delirium is a little bit different for the confusion or end-stage restlessness. And so is it med-related? What's causing it? Is it the body and the electrolytes all off kilter? What's causing the delirium? And that's the hardest thing. So we usually treat it with our lorazepam. We go through that. That's our #1 drug of choice. It's cheap. That's the one we start out with. Haldol is the second drug of choice. And then usually from that is diazepam, which is Valium. Those are our 3 main ones. Occasionally we'll go back to Xanax, but it's not used as often anymore. Definition of pain, this was per McCaffrey. Pain is whatever the experiencing person says it is. It exists whenever that experiencing person says it does. So when a person tells me they're hurting, they're in pain, I have to believe them. And my goal is then to go and say, hey, how can I help you? You've got a pain level, you're rating it high. I also go by facial grimaces and stuff, because some people don't know how to rate their pain, especially in years ago. We'll come to the pain scales and stuff too in a little bit. But, so it's very hard. And so I try to get down, where are you comfortable, where you would not take a pain pill? Because that is different for every person. So when I do my scale from 0 to 10, I'll ask them, if you're gonna take a pain pill, what number would you take that pain pill to get you comfortable? Most people will say about a 4 or 5. And that gives you a range so that you know where to mark it. So that if they tell you they're getting it at a 4, someone needs to give them a pain pill. Or if they're comfortable at 2. Some people may be way off one end or the other, but as long as they can tell you, maybe they'll take a pain pill at 8. As long as they can tell you where they are on that pain scale. And that's why you need to know where their basis is, where they would like to have it. And it's nice to be able to do that when you communicate a little bit to you. And pain can be an unpleasant sensory and emotional experience associated with actual or physical mental or tissue damage. Meaning sprained ankle, you know, you can get pain with that, with the tissue damage and stuff that they have. These are the phases. This is what we use most of the time, is the Baker Long, and our scale does go up to 10 instead of 5. But some people can't report that, so sometimes we'll use the scale to 1 to 5. But we also let our staff know that's the scale rating that we're using in order for it to be consistent. And but usually ours is from the 0 to 10 for most people for the. This is the one for in nursing homes and different things is, okay, in this scale, where would you say is, because they may not be able to give a number to it. Is it mild, moderate, or severe? And that might be the only ones that they can take and tell you. And so I have also used these, especially for the elderly, the ones that are slightly confused. They can't tell you, or they can't think of a number, but they can tell you if it's mild, moderate, or severe. And this one here is the geriatric pain scale. And this is the one that some of the Nielsen Place staff like better. And again, it's just kind of like extreme pain, severe pain, moderate pain, no pain. And so they use this thermometer technique. Treatments options, analgesics. We have the non-opioid, the opioid, and the adjunctive pain medications that we use. So the non-opioids, they have a ceiling effect. That means your Tylenol. You can't give more than 4,000 grams of Tylenol in 24 hours, or whatever your standard is. And so you have to be watchful of that, because some of our medications may have Tylenol in it, and that's what the adjunct means in the beginning, like your hydrocodone, Lortabs, hydrocodone with Tylenol. And so you have to be very careful that we're not adding Tylenol plus another medication and stuff when we're giving it.
And in the home setting with the elderly, wow, you see a lot of that, and they just don't know.
The Motrin, the Advils, use your ibuprofen. It works wonderful for bone pain. We might supplement that with morphine and different things. We have used Toradol in the homes, and the #1 problem with Toradol, you can only use it routinely for like 3 days in a row. If you use it more than that, the potential for GI bleed increases immensely. When I worked in the hospital with orthopedics, we did have a GI bleed because we didn't stop it after 3 days. It was like day 5, they ended up with a major GI bleed. And that was a very big learning experience hospital-wide, and it was one of those things that you'll never forget. So we try to use it. We may have to. Some people that are young, a lot of bone pain, we may have to have that as our backup to help them get through a day or so. It just works well, The naproxen we don't use very often at all. And again, those are the things. And renal impairment, either the drugs are broken down by the liver or the kidneys. And those are the ones that work against the kidneys when we go through them and they're broken down. On our standings, we can start some of the low-grade class 2 without calling the doc. The doc has already signed a hospice standing orders. So I can write an order for Loratab, I can do for Cody, I can do for Motrin and all those kind of drugs. I cannot write an order for the narcotics, which are morphine, Dilaudid, Oxycontin, Onidurgazine, or methadone. I have to have a written script. Hospice is the only place that you can get a 72-hour prescription by phone to a pharmacist. From the doc to the pharmacist, they can take and prescribe it without the hard copy. So in an emergency case, if I need to get a drug, I can call the doc and call and say, hey, this is what I need. Can you speak to our pharmacist so they can fill it? This happens usually on the weekend. And they will fill it, and then they have 72 hours to get the hard copy signed and into the pharmacy. And no other program is going to allow you. You have to have that hard copy before they can do that. We try not to use fentanyl patches very often, and a lot of times we see that in the nursing home. What happens is the doc puts it on. You guys don't need to change it for 72 hours. One thing why we don't like fentanyl patches are they have to weigh a certain amount. They have to have sub-Q tissue. If they don't have any sub-Q tissue, it's not working. How much is being absorbed, we don't know. It should never be used on anybody that is confused. They can't tell you how they're feeling. They can't tell you if it's working. And so that is some of the places that we do not like. The ones that it's very appropriate if you're young, have a lot of body fat, and those are the ones that are more appropriate for. We used to use a lot of methadone at one time, and an example of that is we had a patient that had a childhood bone cancer disease. And he was young, he was in his 50s, and what was happening, these tumors were growing in his bones, and it was crushing and breaking his bones. So what they were doing, it was coming and it would form, and it was just, and so eventually he was totally bedbound. And he was the gentleman that also needed the Toradol. And for that, the only thing that we could find to supplement him with was methadone to help with all the different side effects he was having. It has a long half-life. It lasted for a long period of time, works great for burning pain and all those other things that you have with that. And we ended up supplementing him with the Toradol at times. The side effects that you see, sedation, respiratory depression, constipation, the number one. Number one is constipation. Second, sometimes people will have some nausea, vomiting. Renal impairment, you're going to see more of the itching. Constricted pupils. Occasionally, we see, if they're starting to have these symptoms, we try to back off on them to see if that's what's really causing it. Maybe we gave them a little too much. Sometimes it's that fine tuning of how much pain medication to give them. Adjunctive analgesics. You will see us use the number one drug that we use with all our combinations is going to be a steroid, dexamethasone. It works wonderful for bone pain. It helps, instead of using Megace, this is what we are now to use, is dexamethasone to increase their appetite. And so that works way better than Megace. It's cheaper than Megace. It only costs a little bit of bucks when you take and look at the formulary. And so that's our number one choice for pain management. The benzos, anxiety. Those are your lorazepam, diazepam, all the things that we use to take and help with the terminal restlessness. One of the things that you notice with terminal restlessness, if you get a patient, you put them to bed. No, I want to get up in the chair. You get them up in the chair. 2 seconds, I don't feel comfortable. Would you put me back to bed? No, I need to go on the commode now. Would you get me up in the commode? No, please put me back to bed. I really want to go to bed now. Those are the things that is called terminal restlessness, where they don't feel like they know what to do. They can't tell you what's wrong. They can't tell you what's going on. All they know is they need to do something, and they can't figure it out. And so we give the benzos, and that helps calm that thought process down a little bit so they relax. Anticonvulsants, we use gabapentin for nerve pain. We've also used it for restless leg syndrome and different things. And then they have the phenamines. But the top ones that are the ones that we use most often. Occasionally, we have radiation therapy. We try not to use that after they've been admitted to hospice, but sometimes we just can't get them comfortable. The gentleman that had that bone disease, he did go in for some radiation therapy because he could radiate. Dr. Bollinger could take and give him a couple treatments. In 2 weeks, it was better. until it started breaking through, until he got totally bedbound. Chemotherapy, there's palliative chemotherapy. Again, that's not, depending on the cost of it, is if we can afford to pay it or not. Because hospice is usually regulated to pay for those things unless it's agreed upon. If it's outrageous price, it's out of our formulary, we can't pay for it, then it either goes to the insurance company or it's,
We would have to discharge the patient from hospice during that chemotherapy plan and then readmit them after. We probably have to do that because of the cost.
lidocaine or lidocaine. Lidocaine is like those nice lidoderm patches. They're very expensive, but they do work for some of the elderly because if the receptors fill up within 12 hours and then you take it off for 12 hours and receptors go down. And they do work for some people. I do know that they can have an allergy reaction to that, and what happens is people can see critters behind the curtains and different things. And, but otherwise, that's the only time I've ever seen it other than through lidocaine. The prilocaine, that's like your EMLA creams. We had just a person with valvular cancer, which everything was swollen in the peri area, couldn't touch it, having ball wounds were very, very painful for her. And so what we ended up doing is, after her bath, they would give her prilocaine to numb those areas up and stuff for her, some local stuff. And Metastron is the IV for bone pain, but we haven't used that one, but it's out there, and we try to stay away from because it's just too costly. Different routes for administration. The oral, that used to be the number one. Now you see more of the buccal, and that's what you're going to see a lot here because that's really great for people in the home. You think about doing the sub-Q sets and all these different things, which is the next best thing. But teaching, we're able to draw up some of the medications for people in their homes, label them so that they can give them without any problem, because they can squirt anything into their cheeks. Rectal, if you think about it, that's one of the most invasive things to do for folks. And if they've ever had a childhood problem with rape, incest, you're violating, or if they're a mentally handicapped older person, you don't know what they've gone through in their childhood. There was something that was done a long time ago, and it happened, and so sometimes they'll scream out when you start doing those things, and who knows, were they ever violated as a younger child? We don't know, and that will bring that post-traumatic stress back. So that's one of the reasons why we try not to do a lot of the rectal. Inhalation, that would be like your